بسم الله الرحمن الرحيم. أعزائي طلبة المرحلة الرابعة، السلام عليكم. Today we'll discuss an important step in dealing with diabetic patient, and that is diagnosis of diabetes mellitus. And the diagnosis of diabetes mellitus is important because once we have definitive diagnosis of diabetes mellitus, the next step should be treatment. And the treatment of diabetes mellitus is lifelong treatment. That's why it is very important to diagnose the patient to have diabetes or not before we start him or her on treatment. With the clinical features suggesting diabetes, the diagnosis of this disease is confirmed by fasting plasma glucose more than 7 millimoles per liter, which is equivalent to 126 milligrams per deciliter, or with such clinical features, the random plasma glucose is more than 11.1 millimoles per liter, which is equivalent to 200 milligrams per deciliter. But sometimes we may have equivocal fasting plasma glucose or random plasma glucose. And for fasting plasma glucose, which is between 6.1 to 7 millimoles per liter, equivalent to 110 to 126 milligrams per deciliter, or random plasma glucose level between 7.8 and 11 millimole per liter, which is 140 to 198 milligrams per deciliter. With such plasma glucose levels, we need further tests. We should expose our patient with such equivocal plasma glucose levels to further test. And the test that this patient might be exposed to is called oral glucose tolerance test. And the principle of this test is to measure the plasma glucose level before the test after fasting for at least 8 hours, and after giving the patient oral glucose, the blood glucose levels might be measured after intervals of time. And the most convenient and commonly used oral glucose tolerance test is to give the patient 75 grams of oral glucose and to measure the blood glucose 2 hours after the intake of oral glucose. And for this test to be done, the patient should be prepared beforehand. And the preparation before the test include first, unrestricted carbohydrate diet for 3 days before the test. The patient should be fasted overnight for at least 8 hours, as I have said. Rest for 30 minutes before the test is recommended. And during the test, the patient should remain seated with no smoking. Sampling of blood for blood glucose estimation. The first sample is taken before we start the test, and the second sample of blood usually is taken after 2 hours of 75 grams of oral glucose intake. Now, how to interpret the results of plasma glucose level? In this table, when we have plasma glucose level less than 100 milligrams per deciliter for fasting plasma glucose level, the patient is said to have normal glycemic control. In other words, the patient is not diabetic. when the fasting plasma glucose level falls between more than 100 and less than 126 milligrams per deciliter, the patient is said to have impaired fasting glucose. And once the fasting plasma glucose is more than 120 milligrams, or between 7 millimoles, the patient is said to have diabetes mellitus. And for those patients with fasting plasma glucose which is more than 100 and less than 126, oral glucose tolerance may be done. And after giving the patient 75 grams of oral glucose, normally the fasting or the plasma glucose should be less than 140 milligrams per deciliter after 2 hours. If the plasma glucose is more than 140 and less than 200 milligrams per deciliter 2 hours after the oral glucose intake, the patient is said to have impaired glucose tolerance test. And sometimes patients in this or with this impaired glucose test are labeled to have pre-diabetes. And those with plasma glucose or blood glucose level more than 200 milligrams per deciliter or 11.1 millimole per liter after 2 hours of the oral glucose intake are said to have diabetes mellitus. Keep in your mind that any random blood glucose level which is more than 200 milligrams per deciliter plus signs and symptoms of diabetes is diagnostic of diabetes mellitus. In diabetes mellitus, we used to test the blood for glucose. Such blood testing for glucose depends on enzymatic reaction, which is a glucose oxidase enzyme. Usually this is cheap, automated, and highly reliable. Also, for testing of blood for glucose, we use testing sticks. These sticks are often read with portable electronic meter. They are read with portable glucometer. These are used for capillary between tuberous finger prick testing to monitor diabetes treatment. These glucometers are very commonly used by diabetic patients to measure their blood glucose and to follow or to monitor their diabetes treatment. Of course, we may have variation in the blood glucose, and this variation depends on whether the patient has eaten recently or not. Higher blood glucose level is expected after eating or shortly after eating. And we have many points to be taken into consideration regarding blood testing for glucose. Keep in your mind that glucose concentrations are lower in the venous than in the arterial or capillary blood. Also, whole blood glucose concentrations are lower than plasma glucose concentrations. However, venous plasma value are the most reliable for diagnostic purposes. Also in diabetes mellitus, we may do blood testing for glycated hemoglobin. This glycated hemoglobin usually results from non-enzymatic covalent attachment of glucose to hemoglobin. And the amount of such, or the percentage of such hemoglobin A1C definitely is proportional or related to the degree of hyperglycemia. And because this hemoglobin A1C is related to the lifespan of the red blood cells, it provides an accurate and objective measures of glycemic control over a period of weeks or months. Keep in your mind that hemoglobin A1C estimation may be falsely diminished in anemia or during a pregnancy, or sometimes it is difficult to interpret in patients who have uremia or hemoglobinopathy. An entity that we used to see in the hospital, especially among patients with stressful conditions, is called stress hyperglycemia. And this is generally or sometimes is encountered during a pregnancy, with severe infections, after myocardial infarction, or sometimes because of diabetogenic drugs such as corticosteroids. This stress hyperglycemia usually disappears after the acute illness has resolved. If such hyperglycemia doesn't disappear after recovery of the acute infection or the stressful events, it is no more called stress hyperglycemia. Also, one of the important investigations that we used to do for diabetic patients is urine testing. And usually we test the urine for glucose, also by dipsticks. And the presence of glucose in urine is called glycosuria. But the greatest disadvantage of urinary glucose measurement is the individual variation in the renal threshold for glucose. When you have low renal threshold for glucose, you may have glucose in urine, but with no diabetes mellitus. Such renal glycosuria is a benign condition and has nothing to do with diabetes mellitus. It might be seen during a pregnancy or sometimes in young people. Also, we may test the urine for ketone bodies or for ketones. And this test can be identified by nitroprusside reaction, which measures the presence or the amounts of acetoacetate. Ketonuria is not pathognomonic for diabetes. You may detect ketone in urine among normal people. And what are the conditions in which we may have ketonuria with no diabetes mellitus? This may happen after fasting or after strenuous exercise. Sometimes ketonuria may be detected after repeated vomiting or once the patient has high fat diet and low carbohydrate. So that's why ketonuria is not pathognomonic for diabetes mellitus, but the presence of ketonuria together with the glycosuria makes the diagnosis of diabetes mellitus more likely. Also, we should test the urine for protein, and such protein is usually detected by standard dipsticks. But this standard dipsticks cannot detect small amount of protein in urine. Albumin level in urine less than 300 milligrams per deciliter cannot be detected by the standard dipstick testing. Such a small amount of albumin in urine is called microalbuminuria. And such microalbuminuria can only be measured by specific albumin dipsticks or by quantitative biochemical laboratory measurement. And why do we do test for protein in urine in diabetic person? This is important because it may indicate the development of diabetic nephropathy and or increased risk of macrovascular disease. Other investigations in diabetes mellitus include plasmauria, serum creatinine, serum electrolytes, serum lipids, liver and thyroid function test, in addition to, as I have mentioned, testing for the urine for ketones, protein, or microalbuminuria. Now, after we get sure that the diagnosis or the patient is having diabetes mellitus, the next step is how to manage. And the goals of the management can be divided into 3 stages. Number 1, short term. And by short term, we mean immediate treatment to relieve symptoms such as polyuria, polydipsia, acute infections, and so on. The other stage is intermediate term stage, to return the patient to a physiological state and social life that are as normal as possible. And the third stage of management of diabetes mellitus is long-term one. It is to prevent the development or delay the progression of the complications of diabetes mellitus. Now, what are the cornerstones of management of diabetes? These cornerstones are patient education. This is very important, to educate the patient about his disease. Also, the second cornerstone is healthy nutrition. Number 3, weight control is very important. Physical activity is one of the cornerstones of management of diabetes mellitus. Self-monitoring of blood glucose is also important. And anti-hyperglycemic agents when necessary. However, you should keep in your mind that it is of prime importance that to manage each patient or each diabetic patient individually. What is applied or appropriate for diabetic patient might not be applied or appropriate for other person with diabetes. So you should individualize the cases of diabetes mellitus. And let us start with exercise therapy. It was found that exercise may improve blood pressure. It may improve endothelial function. It may increase insulin sensitivity. It may improve lipido profile. It may improve glycemic control with reduction in the hemoglobin A1C. Ideally, this regime involves moderate aerobic exercise, such as walking, for 60 to 90 minutes per day, or sometimes vigorous exercise for 35 minutes per day. But before the patient starts exercise, blood glucose level should be measured, so that when we have fasting blood glucose greater than 250 milligrams per deciliter with ketones, or greater than 300 milligrams per deciliter without ketones, in this case, the patient should be advised against exercise. He should not start exercise with such fasting plasma glucose levels. Why? Because this may paradoxically precipitate diabetic ketoacidosis. On the other hand, those with fasting blood glucose less than 100 milligrams per deciliter, also they should postpone. They should not start exercise until they have carbohydrate intake before that. What about medical nutrition therapy in diabetes mellitus? Such medical nutritional therapy should also be individualized. It should be individualized according or to patient's lifestyle, exercise regime, eating habits and culture, and financial resources. So the medical nutrition therapy should be chosen according to these parameters. The aim of dietary management, or the aims of dietary management, include: number one, to achieve good glycemic control. Number two is to reduce hyperglycemia and avoid hypoglycemia. Number three, to assist with weight management. Also, to reduce the risk of micro and macrovascular complications. The other aim of dietary management is to ensure good or adequate nutritional intake. And also, one of the aims of dietary management is to avoid atherogenic diets, or those that aggravate complications, such as high protein intake and nephropathy. Dietary recommendations. In diabetes mellitus, consumption of balanced healthy diet is recommended. And according to this balanced diet, dietary energy requirement by consumption of a diet composed of 10 to 15% protein, less than 35% fat, and 45 to 60% carbohydrate. Soluble and insoluble fibers in the diet are to be encouraged. Soluble fibers may decrease the absorption of carbohydrates. Insoluble fibers may induce satiety. Also, alcohol is to be discouraged, because alcohol will inhibit gluconeogenesis and may cause hypoglycemia as late as 8 to 16 hours after its consumption. Another dietary recommendation is food with high glycemic index are better to be avoided. This table shows you recommended composition of diet for people with diabetes. Here, carbohydrates, as I have told you, in the range of 45 to 60% of energy intake. Fat is less than 35% of energy intake. Protein is 10 to 15% of energy intake. And it is important. Weight management is very important in management or treating diabetic patients. Weight maintenance for type 1 diabetes and non-obese type 2 diabetes mellitus. This is very important to maintain normal body weight for those with type 1 and for those who are non-obese with type 2 diabetes mellitus. On the other hand, weight loss for overweight and obese type 2 diabetes mellitus is to be recommended. It is found that as little as 5% to 10% of weight loss in overweight and obese patients reduce the risk of diabetes and leads to an increase in insulin sensitivity. And what are the ways through which the patient or the obese diabetic patient may lose weight? The first step, low or very low calorie diets. And this low or very low calorie diets in a structured weight reduction program for patients who are unable to lose weight on their own. Or sometimes weight reduction is achieved through surgery, which is called bariatric surgery, either restrictive by reducing the bowel circumference or bypass the stomach and upper small bowel. Such surgery is highly effective in type 2 diabetes mellitus with obesity-associated comorbidities like hypertension, coronary artery disease, or sleep apnea. Bypass operations specifically stimulate incretin, like glucagon, like peptide 1. And as you know from previous lecture, incretin augment the secretion of insulin from the beta cell of pancreas. Also, an important step in treating or in treatment of diabetes is the control of blood glucose levels. This is very important to avoid hyper and hypoglycemia, because both hypo and hyperglycemia are major contributors to the complications of diabetes. And the blood glucose monitoring can be done by the most commonly used method, and that is self-monitoring of blood glucose. And the patient usually can measure fasting blood sugar as frequently as practicable. Commonly, it is enough to measure the blood glucose by diabetic patient at fasting, 2 hours postprandial, at bedtime, and occasionally at 2 to 3 a.m. at night. The other way of blood glucose monitoring is by continuous glucose monitoring systems, measurement of serum glucose or blood glucose levels at 5 minutes interval for 72 hours. Tight blood glucose control. In type 1 diabetes mellitus may prevent or slow the onset or progression of microvascular complications of diabetes, such as retinopathy, neuropathy, and proteinuria. But keep in your mind that with such tight blood glucose control, we may face the problem of hypoglycemia. Also, in patients with type 2 diabetes mellitus, an overall reduction in the microvascular complications of 25% occurs with such tight blood glucose control. What about the target hemoglobin A1C that may reflect good control of diabetes? A target value less than 6.5% is recommended. For a pregnant woman with diabetes, the aim should be, or the target hemoglobin A1C value should be 6 or less. Thank you very much.